Soft tissue techniques for the arm and forearm can be applied with a patient in the supine position. So we can do simple cross fibre soft tissue to the biceps, taking a grip on the muscle belly and just stretching it in a cross fibre direction, releasing slowly and then repeating. And this process can be applied along the whole length of the muscle. In order to make the technique stronger, we can increase the elbow extension with the stretch. We can increase the elbow extension with some pronation and wrist flexion, palmar flexion. For the triceps group, we can come more around the back of the arm, gently pulling, once again to create a gentle cross fibre stretch. And we can increase that by flexing at the elbow to lengthen the muscle while we're performing the cross fibre. Coming into the forearm, once again we can work onto the common extensors, increasing the stretch with some palmar flexion at the wrist, or we can work into the common flexors, increasing the length by some dorsiflexion at the wrist. Gapping of the elbow consists of working into 3 joints: the radiohumeral and the humero-ulnar. And the humero-ulnar joint is separated into 2 parts, its medial and its lateral articulations, giving us potentially 3 joints to work onto. If we pick up the arm in this way, so that the more cranial hand is at the elbow and the more caudal hand is supporting the distal forearm and the hand. The lateral border of the hand is the applicator, and that's applied to the lateral side of the elbow at the line of the joint. And the index finger curls around the back of the elbow, gripping and palpating at the medial side of the olecranon. We can then support the elbow with the other arm, taking the elbow from a position of flexion towards extension, but not full extension or hyperextension. Compression can be applied from the sides and from above and below with a little bit of gentle traction, and then using the body we can encourage a gentle medial gapping of the medial humero-ulnar articulation. If a sense of resistance is felt within the joint, this gapping can then be changed into more of a manipulative impulse technique to release the medial surface of the joint. By then switching the body to the medial side of the arm, taking up the grip the other way, so this time the lateral part of the hand will be applied to the medial side of the elbow. The index finger will curl around and come onto the lateral aspect of the olecranon, supporting the arm once again, going from flexion towards extension, but not full extension or hyperextension. We can gently use the body to apply a gentle gapping, focusing to the lateral humero-ulnar articulation. Once again, if resistance is felt, this can then be changed into more of a manipulative technique with an impulse to release the joint. In order to access the radiohumeral joint, which is on the most lateral part of the elbow, and the radial head is slightly more anterior and distal, the therapist needs to drop the front knee to get much lower in order to get the direction such that the force comes out of the elbow anteriorly, laterally and distally. An alternative to this is to go back to the lateral gapping of the humero-ulnar joint position and simply externally rotate the shoulder joint, and that will access the lateral radiohumeral joint. Once again, this can be used as a mobilisation, and in situations of resistance, a small, short, sharp impulse can be applied. The modified Mills technique was designed to manipulate the radial head, and it's called modified because we're not going to use so much extension or hyperextension at the elbow, which was in the original Mills technique. So we're taking up this grip, the more distal hand supporting the distal end of the forearm, wrist and hand, the more cranial hand supporting the elbow. The thumb of the cranial hand is positioned posterior to the head of the radius, and the thumb is going to apply an anterior movement to the head of the radius. The hand is also going to encourage the elbow towards extension and lift the elbow towards the ceiling, which will gap the lateral aspect of the elbow. Combination of these three things will help encourage the mobilisation manipulation. The other hand will actually pull the forearm towards the operator's body, and this will actually be part of the impulse movement to ensure that too much hyperextension is avoided. There'll also be some palmar flexion and pronation, all of which will help to traction the radius away from its position within the elbow joint. When all of these six are performed together, then we can try and build tension by priming the tension, building the tension and preloading the tissues to such a point where we will then achieve an actual impulse of this technique. And one should be aware to encourage the thumb pressure whilst at the same time avoiding excessive hyperextension in the elbow. Mobilisation of the forearm bones is a useful technique in a number of situations, whether it's an elbow problem, hand, wrist or shoulder. And simple anterior-posterior glide movements can be applied to the two forearm bones, gently using the therapist's body weight rather than just arm and hand pressure. The patient's arm can be more pronated and can also be more supinated so that the two bones can be mobilised thoroughly in those two positions. And then a more inferior superior glide can be applied along the length of the bones, once again with the forearm more pronated, more supinated. And finally, a more circular circumduction type of movement can be applied to the forearm bones, once again in those both positions. These techniques mobilise the interosseous membrane between the radius and the ulna, influencing the blood supply and the nerve supply.